I'm delighted to introduce my friend and a mentor, Dr. Paul Grove, who is a research psychiatrist, a clinician, and an administrator, and he has worked in Canada, the United States, Germany, and several other European countries since 1959. He's been at the National Institute of Mental Health in Bethesda, Maryland between 1977 and 1978, and the expert of World Health Organization 1985 to 2000, and a visiting professor at several European universities. Between 1988 and 2005, he worked in Ottawa as the clinical director and later director of the mood disorders research at the Royal Ottawa Hospital in Ottawa, Canada. And at this time, he is the director of the Mood Disorders Center in Ottawa and also professor of psychiatry at the University of Toronto in Toronto, Ontario, Canada. Dr. Grove has authored or co-authored 500 or more papers and 3 books. And Dr. Grove, I'm delighted to welcome you to Vanderbilt.
Oh my goodness, what a generous introduction. I have a bit of a trouble recognizing that in that myself. Well, welcome. I guess I can move to the first slide. I'm going to talk today in the next about 45 minutes I think an important paradox, one of the important paradoxes that we have in clinical practice, where lithium is the first-line treatment for bipolar disorder in practically all 35-plus guidelines, treatment guidelines, international ones, national ones, and yet it's used less. And also there are some data indicating that is effective less than it was when it was introduced. And that's strange. If we believe that we work in an evidence-based medicine, strange paradox. So let me start with a summary, the points I'd like to get across. As I said, lithium is first-line treatment, prescribed less, and described less effective. Now, there are several explanations for this that you can find in the literature. It's been the competitors, particularly the second-generation neuroleptics, have been certainly marketed very aggressively. Lithium can be very easily described as something that requires close monitoring, and in the literature, you'll find a lot of side effects. But in addition, I think there are 3 other factors. There are some misunderstandings that taint the whole story, and I'd like to talk about that. I want to say that I have been in an unusual situation. I've been involved with lithium since 1965, and we've used it in all the programs that I directed, particularly in the last 50 years at McMaster University, in University of Toronto, and in Ottawa. And we've been able to follow large cohorts. We've been able to follow some of the individual patients, a number of them up to 50 years. We've followed some large families for genetic research, bipolar families with more than 100 members. So some of the things, what I'm going to say, reflect this kind of experience, which is not a mainstream experience. So I think that number one, the misunderstanding is who actually benefits from lithium. Who are the people who really get stabilized and stay stabilized? The second source of misunderstanding is that lithium has a variety of benefits that it can offer to psychiatric patients. And one that is particularly confusing is the difference between the stabilizing effect and the neuroleptic-like effect. And I'll go over that toward the end of lecture, clarifying the qualitative differences and how that causes sometimes confusions in the clinical practice. And finally, I think what causes misunderstanding, if you read literature, you get a feeling that lithium is associated with a number of side effects and some of the serious ones. And that's true, but that's not true if the patients are properly selected and if it's the responsive population. The data in the literature describe kind of indiscriminate use of lithium. So, these are some of the statements, some of the literature reports about lithium list prescribed. The one that I'm particularly concerned with, the most recent one by Ree and collaborators, it shows that lithium over the past 20, 25 years has dropped from being used in about 65% of bipolar patients to something like 20, 24, 25%. And this is again for the medication that's supposed to be the first line treatment. And there have been other studies back to 2007 actually, repeating the same story. And there's also reports, and I find the one by Deschal is particularly convincing when he shows correlation between reduced lithium effect and the changes in the diagnostic classification over the years. So, as I mentioned, one of the there are certain explanations that are well known, and you can find them in literature. The aggressive marketing, clearly neuroleptics, second generation, are easier to use in practice. They do have wide use, as you know. For example, quetiapine is now widely used by GPs all over the world for anxiety and sleep disorders. And lithium does require a bit closer monitoring, and certainly the fears of side effects play a role in the reduced use. But there are these other misunderstandings that I think we certainly identified and colored the whole picture and thinking of clinicians about this issue. I find it helpful to go back and go through just briefly through the history, how this actually happens, because I think it does explain the situation. And you will see I have slides, and it's probably very unusual in 2020 that I'm going to only show one neuroscience slide, but as we go through the presentation, you will see clearly why. So, I have two pictures of patients who were put on lithium in 1969. And the point I'm going to try to make is that the patients that were treated with lithium initially were quite different. They were severely ill, very frequent episodes. Some had 10, 15, 20 years of illness when they came to us. Were spending sometimes 1/3 or half of their life in hospitals. There's another one where I guess some hypomanias were not recognized initially because relatives felt that isn't that natural when you get out of the depression that you get a bit elated after half a year in the hospital. And these patients went on lithium and stayed well for 20, 30 plus years. And this is certainly quite different from most of the patients we treat today when they come after the 2, 3, or often now is the first episode, and you need to decide what to do. At that time, many patients, but not all, responded very well. And this was puzzling. This looked a little bit, some of the situations at that time looked a little bit like miracle, such a response to a simple ion. So the big questions on our mind and my mind was certainly who responds and who doesn't, and what could be the biological explanation, because if it's such a simple ion, there has to be some simple biological explanation. Well, because it looked so miraculous, of course, lithium has been tried in many psychiatric conditions between 1970 and 1980. The average psychiatrist has some difficult to treat patients. That's unavoidable. So, as you would not be surprised that the excellent results were found certainly in what was at that time diagnosed with manic depressive illness and later turned into bipolar disorders correctly. But number of depressions were responding because number of patients with frequently recurrent depressions in fact have a bipolar basis. But that was not all. People started noticing benefits in schizoaffective disorder, and you have at the bottom of the slide you have some of the reports from that time. There was particularly a Cincinnati group, it was David Carver and Hirschowitz, who studied what was described as schizophreniform psychosis, patients who were quite ill, either mood changes and psychotic symptoms, or sometimes even just psychotic symptoms, but very good recovery. And I think quite similar to what the Europeans and Scandinavians particularly described as cycloid psychosis, these illnesses with very good outcome and recovery. So, and there were some other conditions that benefited impulse aggressiveness, particularly in some of the forensic patients, and a questionable issue. At that time, Nathan Klein in New York was very enthusiastic about the use in alcohol addiction. It remains kind of certainly controversial issue. But even last year, there was another report from New Year's and observations from New York suggesting some possible benefits in patients with alcohol addiction. And there were a number of other conditions where lithium did not do anything. But the question was, what do you about the other people who are not bipolar and benefit? So the conclusions at that time were drawn, and you could go back in the literature, you would see that. Obviously, if this is a drug that makes bipolar patients completely and enduringly well, it's must be specific for the illness. And therefore, the patients who benefit from lithium must have had unrecognized bipolar illness, and we have to find a way to properly classify them. Unfortunately, that was the way things looked at that time, and the subsequent research certainly shows that those conclusions, those generalizations, were just too hasty and not quite logical. So my big question at that time was, how come that there are bipolar patients who come and at the symptom description, they did not look any different, and yet good proportion of them did not benefit from lithium. And so we spent the next 25 years looking for the biological differences and hoping that we're going to find some clear biological, or possibly in combination with some psychosocial indicator, predictor that will make it possible. And we did have number of promising, interesting findings. Unfortunately, as you use that kind of approach, there's been huge advance in technology in those 1978 to 2000 years. But as we were using particular approach and measuring and finding differences, as we learned to deal properly with the confounding factors, the differences very quickly went away. And eventually, and it was a difficult methodology, and it remains difficult methodology. It seems like clinical practice. You see the bipolar patients, put them on lithium, either they do well or they don't do well. But it's not like that for research. There's number of false responders, and number of who had actually very capricious course of illness, and the periods without episodes were just coincidence, just natural course. Keep in mind that follow-ups of patients who discontinued lithium from bipolar spectrum, about 1/3 remains without recurrences for 5 years. It's the course is capricious, and the other problem is compliance. There are a number of patients we were finding who looked like non-responders until we had a nurse to sit down with them for half an hour, worked out the compliance issue, and suddenly they were responders. And for research, it was important to have people who are clear responders and clear non-responders. And the other methodological challenge, as you will see, was the variety of benefits, particularly the neuroleptic-like effect in some patients. And so when we eventually did proper multivariate analysis, particularly discriminant function analysis, it turned out that the only feature that one could really rely on a use for clinical practice was the clinical profile. And that's the reason, if I was giving the presentation of lithium response number of years ago, it would be 80-90% would be neurobiological slides. You will only see one today for these reasons. So we certainly were fortunate. I think we had a good clinical material. People are still interested now in children and grandchildren of our cohorts. We did work with some excellent excellent laboratories. The platelet monoamine oxidase studies we did with Dennis Murphy, the top guy at NIMH on platelet MAO. The red cell lithium study we did with Barney Carroll in Ann Arbor, neuroendocrine responses. We did with Greg Brown in Toronto, neuroendocrinologist. The genetic work we did with Neurogenetic Laboratory in Montreal, yet we could not find. There were only two significant differences. One was in the MNS blood groups, where the responders had significantly fewer N groups. However, this was only a statistical difference. It did not contribute in any way to individual separation. And the neuroendocrine responses were very clear and clearly showing some, were compatible with some serotonin and endorphin dysfunction in the lithium responders, but it required two stays in the research unit. You had to get the patients off medication, do the testing, put them on lithium, and 3 weeks later, repeat. It was $2,000 each pop. And interestingly, when we did the multivariate analysis, essentially the differences that were coming from the neuroendocrine responses were already captured in the clinical profile. So at the bottom you have some of the publications where we reported that, and it's a clinical description essentially. The most important, the factor that draws most of the explainable variance is actually clinical course. Fully remitting, episodic, no residual symptoms. And if you, by no residual symptoms, I mean people even don't complain about anxiety or mood fluctuations or sleep problems, because they seem to be able to differentiate very well what was the episode and what is just a variation of health. And if one had patients with clear previous history, which of course you will not always see these days, they had predominance of depressions. The other factor was family history, very clear family history of episodic disorders, psychiatric disorders, obviously bipolar, but also frequent recurrent episodic depressions, and other. If we have time, I can talk more about what you find in the families of the bipolar lithium responders, where you can have a variety of other psychopathologies, but coming back episodically and doing very well on lithium. Comorbidity in this population, just similar to the general population, 4-5% of addictions, alcohol or other addictions, but not more. And in but the presentation, and this is the frustrating part, I find, what we really base our diagnosis, the clinical, the classical, the clinical presentation contributes. Of course, it's helpful, but by itself certainly does not differentiate. And if the patient has the classical symptoms, the sadness, the desperation, the sleep, early morning awakening, it helps, it contributes to the selection, but you cannot rely on that for selecting lithium responders. In the initial cohort, we also had in the responders no prepubertal psychopathology. And now we have 25-year follow-up of the children and grandchildren of these patients, responders and non-responders, and we don't find this difference anymore. So that was either it's just this new generations have earlier problems emerging, or it was a methodological problem that the patients with episodic type of disorder kind of rewrite their past, and if the symptoms were not similar to what they were experiencing later, they just disregarded it. In any case, it does not help at this point to differentiate. Now, at the bottom you see some of the replications of this. The Halifax group did a double-blind study coming to the same conclusion, and Jin Mali and Sam Gershon published a paper in Bipolar Disorders 2013 coming to essentially the same conclusion. I think he talks about classical treatment for classical disorders. Now, I mentioned that because Sam Gershon is somebody who's used lithium since 1950 for 70 years. He actually, was in touch with Kate at that time in Australia. So I think his word counts something. Now, when my response to these findings initially was mixed, I was very disappointed that we did not find some simple biological explanation of the difference. But the pleasant result was that you actually, with a comprehensive assessment of clinical profile, can predict the lithium in more than 85%. And if you have a solid data on family history and clinical course, even more than that. And that's now seen by other people as well. Now, when I thought about it, it started making sense. The 6 groups that published such positive results with lithium, having both prophylactic effect for mania and depression, were essentially Kraepelinian trains. Scow, Bastrup, Koppen, Hallin, they all grew up in Kraepelinian tradition. And so, if I can just remind you how Kraepelin described manic depressive illness, it just resonates very much with what we had to find many years, century later, using multivariate analysis. His basis was symptom description. Patient had to have recurrences. There had to be full remissions in between episodes. He called it, I'm talking about clustering in families, he talked about hereditary appearances of these disorders. And he insisted that these patients have hallucinations and delusions, have psychotic presentations, relatively rare, and they tend to be more congruent, and they are transitory. And what happened since the 1970s, 1980s to accommodate the other patients who benefited from lithium, these criteria were one after the other gradually dropped. Certainly, you can have psychotic phenomena, bipolar disorder. You don't pay attention to family history. You don't usually know about the clinical course enough. Recurrences are nice, but they are not required in either ICD or in DSM systems. And so we then give lithium generally in practice to variety of bipolar disorders and end up with a variety of results. There is a recent replication by Noonan that was published at the Psychiatrica Scandinavica, and it's a fairly large cohort that they put together from collaboration, maybe in the, I think all members, are members of the ICSLI group, the International Group for the Study of Lithium-Treated Illness. They used the sexy machine learning approach, random forest model, 180 clinical predictors went into it, and again, lithium response was predictable based on essentially clinical profile and very low positive, false positive rate corresponding with what we're finding now, predicting the response in patients and selecting patients based on their clinical profile. The other interesting finding from that was from that study was that responders are genetically distinct. You can separate them from non-responders. The non-responders don't have genetic characteristics, but the responders do. And the informative genes are particularly the ones tied up with G protein coupled receptor. In other words, with the signal transduction systems, but there are other genes playing along as well. And this is the only complex slide I'm gonna show that illustrates the genetic findings, and it just makes me feel like a fool when I was hoping for some simple solution to the prediction of response. Now, Noonan had to follow a similar strategy as we did, which meant, yes, we put patients all on lithium, but when we looked at responders or non-responders, we only looked at the patients where it could be clear. In other words, these were responders who had sufficient risk of further recurrences for the period we were giving them lithium, and yet they were free. And non-responders where we eliminated the problems with non-compliance, taking blood sample at each recurrence and making sure that it happens on a sufficient dosage. He has to, in a way, do the same to get a clear genetic results. And in that part of the 1,200 plus cohort, the differences between responders and non-responders are clear and very much resonate with what we found with discriminant function analysis. In other words, the non-response is clearly caught with non-episodic course, rapid cycling, frequent presence of psychosis, anxiety, clearly comorbidity, and these are even epidemiologically clearly different populations, different cohorts, and the age of responders is around 30, which is what we found in these large bipolar studies with Joe Angst around 1975. Now, I think a few more minutes to mention briefly the second point, And what, of course, turned out over the years, and that was not obvious in 1970, well, 75, when the classification started changing, that lithium indeed has a variety of benefits. The stabilizing one is probably the most interesting for clinicians like us, but there is a number of other ones, and I'm sure you know all of them. The interesting thing is that you can only put your money on the stabilizing one as unique, because with all the other effects, there are other ways. Certainly you can achieve antipsychotic treatment with antipsychotics. You have a number of treatments for manias. You can augment with thyroid and other things. But the question is to what extent anti-suicidal effect is specific. But if you think about anti-suicidal effect of clozapine, even that, it would not be that specific. But it's the stabilizing reflect that really stands out, that something that's not at this point not replaceable. Not that people haven't tried. There's been trials with rubidium, cesium, other things, but nothing really came out as clinically, not so far, not at this point. What is this effect in the classical type, in the responsive type? It has the following characteristics. It's stable over years. There's a Ixley's report on nearly 400 patients showing the stability of the response over up to 20 years. And it goes beyond that. It's been only studied up to 20. The antidepressant effect is present not only in maintenance, but it's also in acute population. These patients, when they go off lithium and eventually get depressed, the best treatment for them is to renew lithium. Usually they are markedly better within 7 to 10 days, and usually they are out of the depression within 2 weeks. In this particular group, certainly not a general antidepressant, but the other thing is, in this group, when they stop lithium, they and eventually have to go back on it, it responds again. And I'll show you the Garver observations. This is not true for schizoaffectives or schizophrenic for majority of them. This is characteristic of the lithium responsive, the classical type. And I'm sure many of you will be familiar with the huge rebound you can get in some of the patients when you discontinue lithium suddenly, or when the patients discontinue lithium suddenly. But this is not true. There are studies reported from 1970 papers showing that in that population, there was no rebound if the patients discontinue lithium remission. And if they discontinue it suddenly, that doesn't have to be even gradual. So it's a clinically different situation. The other thing is these conditions also cluster in families, and we showed that in 2002 in one of the papers on about 250 patients. Now, but this, you will see how different this is from the neuroleptic effect of lithium. It was best described by the Cincinnati group, but also some Europeans described it as well. What happens is it has different characteristics. First of all, lithium only helps the overactivity, does not do anything for the low periods of low mood. It's poorly reproducible. The Garver and the group found that if the patients benefited and then discontinued and tried to go back, at least half of them just did not get anything out of that. And there is striking rebound when these are some of the most frightening situations I have seen when patients who had neuroleptic-like effect and stop it suddenly, the rebound psychosis are very, very acute. And again, you cannot assume if you find a patient with neuroleptic-like effect that the relatives will benefit. That's also obvious in the 2002 paper. This is just a summary, again, that the, contrasting the two, that in the stabilizing effect, you have benefit both in mania and depression, both acutely and in maintenance. There's no rebound, and the response as a rule is replicable and clearly clusters in families. And finally, just very briefly, the side effects during appropriate treatment, during the treatment of patients where there's a predictable response, are much less than is generally described in the literature. And so when we talked about the patients who are suitable by clinical profile, who have been educated how to use lithium properly, and where the dosage is tailored according to their age and sex, the side effects are much less problem. I'm just contrasting here the most commonly quoted study of side effects. There's McKnight and group in Lancet, 2012. You see significant side effect problems, and these are data from SCO's cohort, quite significant differences. These patients generally only complain about thirst and that they go and void, at least 30% of them, and majority actually don't feel any side effects, don't report any side effects, even on questioning. So, in summary, what I wanted to communicate is that lithium stabilization effect is predictable, but unfortunately, the genetics of it is still too complicated. We still have to rely on the patient's clinical profile, but it can be done quite well if you can get good data on a clinical course, the family history, comorbidity in particular, and some of the data from the clinical profile, from the presenting symptoms, of course, help with that. The second point is that in addition to the stabilizing effect, number of patients can also benefit from the neuroleptic-like effect. But then the clinician needs to be clear that he has to change the expectations. It has to be very clear that the medication is not acutely interrupted, that we'll still have to do something about the low moods if they appear. And finally, that the description of side effects in the literature, it does not give a full story, does not give a full description, because I think we should be primarily concerned about side effects in patients who have been properly selected, who will benefit from lithium, who will stabilize on it, and who should stay on it. There is no point staying on lithium, and I've seen it many times in consultations, where the patients are kept on lithium either alone or usually on combination with many other drugs, but there has not been any benefit. They have side effects, including number of side effects from lithium. From all studies that we've done, we published one in American Journal, I think, a number of years ago, showing, for example, the very different effect on urinary concentration and urinary volumes, that you get virtually no increase in just 100 to 200 milliliters in volume in the lithium responders, and very marked increases in people who did not do well on lithium but were kept on it. Well, I think there's too much, so much more one could say about this, but that's the main point I wanted to get across. Thank you very much for having me. You cannot clap because people would have to turn on the microphone.
I just wonder if anybody has any questions or comments.
You can put a question in the Q&A or raise your hand and I can allow you to speak and ask your question out loud.
I suppose I can stop the sharing, right? Yeah. Either I have been completely confusing or completely clear.
Dr. Martin has a question. Dr. Martin, do you want to ask that out loud?
Yes. Thank you so much for this incredible presentation. It's it's really nice to see this history. I would like to ask the question, and this is kind of a silly question in a way, but I guess what I got from you was that the $1 million question is, what's the difference between? Basically, is to distinguish the responders from the non-responders, and if you understand that at a more fundamental level, it would be wonderful.
Unfortunately, that's not a silly question. I may end up with a silly answer, but that's a different issue. It's a pathophysiology. These are two different disorders. When we have a group of patients that we have been able to follow up to 45 years monthly with biological testings, and we have data, for example, on DST, which is something that anybody can do and check. And what happens with the responders, there are oscillatory processes that take place only in the frontal parts of the brain, from the prefrontal cortex down to hippocampus, amygdala. The physiology of those neurons is that any waves of oscillatory waves just go quickly through the whole area, and this is a very different pattern in the non-responders, generally in the bipolar spectrum. And of course, we know much more about the responders, non-responders, but the data that we have from non-responders suggests that these oscillatory waves actually go all the way to cerebellum. They are very irregular. In the responders, there is an interesting phenomenon. Maybe I should preface it. I feel that there is a very important message about the nature of bipolar disorders from the study of the clinical course, and unfortunately it has not been done very, very well, and for various reasons. But it's a different pathophysiology that we can see. The responders have, interestingly, they lose the adaptivity. But people who don't have bipolar disorder, and probably others, have a very adaptive response to the oscillatory processes in the brain. People with the classical bipolar illness have quite fixed cycles, which is interesting because that makes it possible. You can actually, once you identify it, you can actually predict what's going to happen. I don't know whether I can get to I could show you some of the slides. We have a group of patients, about 30, who we treat with lithium intermittently because it's possible. Because of the rigidity of the oscillations, you can actually predict the risk periods. And the huge advantages that in these patients, even after 30 years or longer, you don't have any significant side effects on glomerular filtration. And I guess I should not, I was wondering, I thought I forgot something. At the end, I was hesitating because I guess I did not say about the side effects. One thing that we are discovering is that there's still a big problem, I think, for clinical practice. Now when we are seeing patients on lithium continuously for 40, 45, 50 years, and I still struggle with getting proper control group. You can imagine it's difficult when you talk with this kind of time dimensions. But I'm convinced that a very significant proportion of my patients after 30, 40 years have significant reduction of glomerular filtration. And these patients with intermittent treatment don't have it. So the answer is those are two different pathophysiologies. That's why I think they behave differently.
Thank you, Dr. Grove. We have some more questions as well. We have some that were submitted written, and we also have someone else who would like to ask a question aloud. Dr. Satterthwaite has asked two questions. One is, how much of an effect do you think the particular fear of nephrotoxicity contributes to physicians not prescribing lithium long-term? And she had a follow-up to that question as well.
It's very substantial, and I think it goes in waves. It became very major problem around 1977, where one of the Danish investigators, basic science investigators, found considerable number of morphological changes on the biopsies in lithium. And so for several years, people backed off for lithium. Then, of course, it turned out that she only had a sample of people who had repeated lithium intoxications, which is certainly not a usual kind of the population that we treat, and then things cleared up. But it is a concern, and it is certainly a concern on my mind. I mean, we tested very carefully patients the first 10, 15 years, and we did not, we found 5% drop, which was exactly the 5% of, were the same patients who had reduced glomerular filtration prior to going on lithium. But I think after 25 years, 30 years of continuous administration, it is a problem, and that's why the solution would be, and I think this is ideal, would be to treat patients with lithium in specialized clinics and put the effort into identifying the underlying cyclic behavior and treat them intermittently, or find something better. What was the second question?
Her second question was, have you seen frequent decline in kidney function in your experience when people are on lithium for years? As an early career physician and hearing that nephrotoxicity in long-term use is almost inevitable, and seeing CKD2 lithium in the outpatient setting, that is my biggest concern in managing patients on lithium.
Yeah, I fully agree. And I think it's we certainly paid a lot of attention to it initially and then in recent years. And I think the big fear comes from patients who should not be on lithium. There's number of patients kept on lithium just because they have a bipolar diagnosis. And I think that's a mistake. I mean, I think the strategy should be, if you can predict the response based on clinical course, then the patient should be kept on lithium. But then you can keep those patients on monotherapy. You may need hypnotic, but you don't need any other medications. But then there are patients with clearly chronic courses, and one should be very cautious. Just because of bipolar diagnosis, they should not be kept on lithium. And then there's a group in between where either we don't have sufficient information, or it looks promising and the clinician feels strongly that patients should be tried on lithium. Particularly this happens in young people. they should have a trial on lithium, but then it should be a trial. There should be a point at which one would say, does the patient benefit? Should they stay lithium or not? Should we go in other direction? The pathophysiologic condition is different from epilepsy. This is the idea that these patients require polypharmacies, all of them. I think it's not justified.
Thank you. I have somebody who would like to ask a question out loud.
Well, I'm very glad about her question, because I think she's getting it right on. This is something, the nephrotoxicity will have to be clarified, but it's not as bad if lithium is used properly.
Okay. All right. Can you hear me?
Yes.
Yes.
Okay, great. Thank you so much for a wonderful talk. My question, one of the things that jumped out to me during your talk was this, multiple pathophysiology and the difference between somebody who has this classic episodic bipolar disorder versus some other bipolar spectrum disorder. And so I'm somewhat disheartened by the fact that our best predictor is kind of the clinical profile, because we're notoriously bad at predicting that clinical profile. And, especially when we have young folks coming in first, second manic episode who may have had a unipolar diagnosis for years before that, we're really poor at predicting who is going to go on to kind of having a relapsing, recurring episodic bipolar disorder. So my question, I guess, is how long does that trial last? Like, if we put people on lithium because they've had a manic episode and we wait to see the trajectory of their clinical course, like, how long is too long? How short is too short? Is kind of my clinical question.
Yeah. First of all, well, there are two parts to it. One is the question of the clinical profile, and the other one is how long the trial. Let me start with the trial. I feel that has two parts. One is what we recommend, and the other thing is what the patient and the family are comfortable with, and eventually I think it has to be determined by what the patient and the family are concerned about and want. Our this recommendation, I think, would be based on the frequency of the episodes, would be based on the severity of illness, and it would be based on the impact of the illness on the person. The perspective of the patient and the family is often different. I mean, I'm thinking about a patient we had a long time ago who was a chairman of the Department of Internal Medicine and played a major role in the faculty. When he had manic episode, after that, when we got together with the family, we were getting calls from different people in the department. So never off lithium, never, just has to stay. No time limited trial. So I think it would be these three factors that one would have to consider. And the other factor, I think I find it very helpful in that situation. If somebody's on trial, ask them and to keep track on a simple 10-point scale, see how stable the mood is, and have it confirmed by the partner. Because if you certainly will need to continue if there's a lot of instability continuing. There is, so I think the length of trial really has to be negotiated with the patient and the family. The issue of assessing the clinical profile, you hit it right on. And the problem is, it seems simple, clinical profile, but the most powerful predictor is actually the episodic course. And we are trained and have been trained for a long time to identify clearly psychopathology. We are not well trained to identify mental health. And that's a problem. the residual symptoms, one really has to learn, one has to observe now the patients, question them, learn to assess whether it is an episodic course or was it just an illness where the patient has a functional remission, gets back to the family, gets back to work. But there are residual symptoms with sleep, there are residual symptoms with anxiety, there are residual symptoms with irritability. I find I use in those situations where I'm not sure from the clinical assessment, I do the psychological, I do MMPI still. It's quite helpful actually to identify and keep track of daily ratings.
Thank you very much.
We have 3 more questions, but probably not enough time for all 3 of them. Dr. Frock asks, how much benefit do you think there is to being on a dose for augmentation, i.e. not a therapeutic level, and could a lower dose mitigate some of the potential long-term risks that have been discussed?
Low dose definitely may reduce substantially the risk. What we found doing the red blood cells, it did not differentiate eventually between responders and non-responders, but we found out that there is very substantial fluctuation in intracellular lithium. And so you have a plasma level and you think that it's a therapeutic level. It may not be. And you may have good therapeutic level and you think the patient should stay on it, and it may be too much for the person. One has to look also at the side effects, not just levels. So from that point of view, somebody may have. We have women doing quite well, older women on 0.45 level or 0.50 level. But some of them, when you do erythrocyte lithium, you find that they have, so let's say, 70 or 80% saturation in the cells. So yes, that I think that makes sense to use lower dosage, and it may benefit. The second question was, sorry.
Oh, can you see them, the questions?
I should have.
We are unfortunately running out of time.
Yeah, I don't see that question. Do you remember what
one says, can you comment on lithium adherence and reasons for non-compliance in patients who respond well?
Oh, yes. It was a huge discovery. The compliance with psychiatric medications is much more of a problem. We never thought. I found out when we started using lithium in Canada, we had difficulty getting plasma levels. It just took too long. So I bought a flame photometer and we did the levels as the patient came in. It was an eye-opener. How we in clinical practice mix up good transference of the patient with good compliance. You feel that you have a very good connection with the patient, so you assume he says, I take it. And we had situations, patient was, oh yes, I've always taken it, I never missed. Past months, never. Plasma level was 0.3. Oh, it must have been just last night, And so what is very helpful, what we eventually had a nurse on the team trained to deal with the questions of compliance. Because compliance, it has complexity. There are practical issues, remembering, and there are psychological issues. If the taking the medication reminds you of the illness and you don't want to think about that, it's going to be a problem. So we eventually trained a staff who dealt with these issues and sat down for half an hour with the patient, and that improved considerably compliance. It's a huge problem, not well recognized. Try it yourself. Try to go on vitamin for 3 weeks. You see how quickly you start forgetting.
Well, Paul, thank you very much. I'm sure I'm speaking for everyone to say how much we've enjoyed your presentation. And really appreciate your insight into the use of lithium.
It was a pleasure to be. I was in Nashville sometime in the early 70s, but that's a long time ago.
It's changed a lot.
I would think that the department has changed, yes.